On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Aditya Yerrapragada. Dr. Yerrapragada is fellowship-trained orthopedic foot and ankle surgeon. Having completed extensive training in foot and ankle surgery, he is highly skilled in treating a broad range of conditions of the foot, ankle, and lower leg. He uses the most modern methods of treatment and minimally invasive surgery. He sees patients at Boulder Center for Orthopedics and Spine in Boulder and Broomfield. Welcome, Dr. Yerrapragada.
Thank you, Karen. My name is Aditya Yerrapragada, and I'll be giving a lecture tonight on foot and ankle hiking injuries, how to prevent and treat them. But before we get into the lecture, I wanted to tell everyone a little bit about myself. I went to undergrad at the University of Texas in Austin, Texas. I then went to medical school in the University of Louisville in Kentucky. I did my orthopedic surgery residency in the University of Washington Medical Center in Seattle, Washington. And I did my extra year of specific foot and ankle surgery training in Baltimore, Maryland. As Karen mentioned, I specialize in all things foot and ankle and many things involving the knee and lower. Listed here are some of the things I do, including Achilles tendon surgery, flat foot reconstruction, ankle arthroscopy, bunion care, arthritis care, ankle replacement, and cartilage repair and restoration. When I'm not operating or seeing patients in clinic, I enjoy many things that folks here in Colorado do, such as snow sports, hiking, spending time with my wife and my two boys, and try to get out as much as I can. So the overview of the lecture, I'm going to start briefly talking about the anatomy of the foot and ankle. Then I'll go into some common hiking-related conditions. I'll go over some non-surgical treatments to address those, briefly touch on the operative treatments for these conditions, and then talk overall about good preventative care to help prevent these conditions from happening. So starting with the anatomy of the foot and ankle. So the foot and ankle has at least 30 bones. Reason I say at least is many folks have extra bones that are very normal, very common. And these bones, there's over 33 different joints and articulations, meaning where these two bones meet together to provide motion. Along with these bones and joints, there's over 100 different muscles, tendons, ligaments, and soft tissue connections. So as you imagine, the interplay of all these structures in your foot and ankle are very complex. So now let's dive right into common hiking-related conditions. In general, hiking injuries, the reason that they happen, folks are hiking over long distances, uneven surfaces, and because of that, there's two main types of pathology that I see. Overuse conditions and acute trauma, slips, falls that result in injury. One of the most common things I see are different types of tendinitis. Tendinitis is simply just inflammation of the tendons resulting in pain and swelling. Tendons are what connect our muscles to our bone and allow for motion in any part of our body. Common locations in the foot and ankle are on the outside or lateral side of your foot are your peroneal tendons, which allow for eversion or bringing your foot out. On the other side of your ankle is your posterior tibial tendon. This can also get inflamed. This muscle and tendon controls inversion of your foot. And lastly, another common one that I see is Achilles tendonitis. And the Achilles allows us to point our foot down or get up on our toes. Tendinitis in general is an overuse condition. And typically the symptoms are presented with activity-related pain. Often gets better with rest. Can often be associated with swelling over the affected tendon and often is very tender to touch in that same area as well. You often have underlying partial tearing of that tendon. Now, the tearing that you have is typically not acute. It's more degenerative in nature, meaning wear and tear over time results in small tears that can develop in the tendon that can eventually become symptomatic. And oftentimes, just like with most inflammatory conditions, it responds to anti-inflammatories. Another common thing I see in my clinic is plantar fasciitis. What the plantar fascia is a thick band of tissue going from your heel to your toes that supports the arch of your foot. Repetitive overuse in this area results in micro tears that can cause inflammation. And as I mentioned, it's a very common condition. Pain is usually at the plantar heel. So it's at the base of the heel on the bottom of the foot, but can often be involved in the mid portion of the arch as well. Oftentimes, worst pain is in the morning or after prolonged sitting, or on the other end of the spectrum can happen after prolonged ambulation. Risk factors for developing something like plantar fasciitis: obesity, meaning increased body weight, can stress this thick band of tissue. Calf tightness is a very common thing that I see that can result in plantar fasciitis. Calf and Achilles work together with the plantar fascia to allow motion. So one being tight can result in the other getting inflamed. And lastly, another common risk factor is endurance activities: running, hiking, dancing, those kind of things. Another condition I see is something called metatarsalgia, which is pain at the bottom of the foot, typically at the base of the toe or what's considered the ball of the foot. This diagram demonstrates the location that you may feel it on the bottom of your foot, and it's increased pressure on the lesser metatarsals, lesser meaning your second or third toes at the base of those. Oftentimes people feel like there's a pebble in their shoe or a bunched up sock in that area, and they look down, there's nothing there. It's typically just increased pressure from the bone. Risk factors: calf tightness is another one. Overuse can result in this, and in general, some people are predisposed to having this if they have a longer second metatarsal. So on this x-ray here, you can see this metatarsal is longer than your big toe metatarsal. Typically, the big toe is the longest metatarsal, but if the second one is longer, they can get increased stress with weight bearing. Something that's often mistaken for metatarsalgia is something called a Morton's neuroma. What a Morton's neuroma is a benign growth of a nerve that lives between your toes. It's the symptoms that you feel are pain, numbness, or tingling that radiates into the toes, most commonly seen between the third and the fourth toes, sometimes in the second and third as well. It can be associated with clicking at times, and that clicking sensation you feel is the benign growth of the nerve rubbing between your metatarsals as you are active. A common risk factor for this is wearing narrow, tight shoes. The reason that happens is if you imagine your shoes compress your metatarsals, which then in turn compress that neuroma, which can cause inflammation and subsequent pain or numbness or tingling. Another thing that I see often: stress fractures. So what a stress fracture is an overuse related fracture. Repetitive micro trauma results in the development of these fractures. There's no acute injury typically. It's a overuse thing that slowly gets worse over time. It can be anywhere in the foot. Commonly, it can be located in the metatarsals, which is in this region here, the calcaneus, which is the heel bone, or even higher up in the fibula, which is part of your ankle. Common risk factor: low vitamin D. And what I tell a lot of my patients to do, regardless of what conditions they have, is to take some vitamin D supplementation just for overall bone health. Poor nutrition can weigh into this, not as commonly seen here, but can happen. And poor bone quality. And by poor bone quality is, as we age, our bone density decreases, so things like osteopenia and osteoporosis can predispose you to developing stress fractures. Oftentimes, x-rays with stress fractures are normal, meaning they don't show anything, but later on in the disease, you'll see evidence of bone healing. An example of that would be in this x-ray here. You can see this cloud of white substance in the x-ray. That's all bone that this person's body is trying to heal that stress fracture. As you might imagine, stress fractures are painful, and typically you're able to localize it to one spot. It's mildly tender, and then there's an epicenter to their pain where it's just the worst pain you can imagine. Pain is worse with activity or weight bearing, typically gets better with rest, and often associated with swelling. The most common thing I see from hiking, though, are ankle sprains. And in general, ankle sprains across the board is the most common reason for missed athletic participation, regardless of age, activity, gender, sport. Typically results from an inversion injury, which is demonstrated here, where your foot rolls in, and as a result, your lateral or outside ankle ligaments get stretched or torn. You can see a diagram here where the ankle ligaments on the outside of your ankle are stretched and subsequently are often torn. The sprains in general are on a spectrum, meaning there's no black and white, cut or dry, good sprain, bad sprain. There's a continuum of disease, anywhere from mild to really severe. The symptoms of an ankle sprain: bruising, swelling, and it can be very painful, often on the lateral or outside of your ankle. Depending on the severity of the sprain, you may or may not be able to bear weight. And because of that, symptoms can often mimic a fracture. So it's oftentimes with bad sprains hard to rule out a fracture. So my rule of thumb is, when in doubt, go get an x-ray. The next level up in terms of severity of injury from a sprain is a true fracture. And it's resulting from a trauma, a fall, a slip, or an injury. Sometimes even with just minimal energy or minimal force. It can involve any bone in the foot and the ankle. Here on the left, this is an example of an ankle fracture. That's from a rotational twisting injury. The middle picture denotes what's called a Jones fracture, or a base of fifth metatarsal fracture. Also often results from an inversion type injury. The X-ray on the right demonstrates a heel bone fracture, a calcaneus fracture. Now, these are typically high energy injuries, but can happen with some high falls or jumping or landing from more treacherous hikes. And this is the bone here that's broken. You can see some fracture lines through here. Fractures, similar to ankle sprains, you'll have severe swelling, bruising. Bruising typically develops after 3 to 5 days, and pain. Most fractures, typically unable to bear weight, and that's usually a good rule of thumb. However, being able to bear weight does not rule out a fracture. So always my recommendation is to get an urgent x-ray, whether that's with an urgent care or with an outpatient specialist. Treatment, depending on the fracture, can be non-operative or operative. So a lot of folks ask or think that all fractures need a surgery. Not the case. In fact, the majority of fractures can be managed without surgery safely. There's, depending on the bone that's broken, different indications and reasons to go forward with surgery, but most of the time fractures do not need surgery to fix. Achilles rupture is a pretty serious condition that can happen, and can happen with hiking as well. It's a sudden dorsiflexion of the ankle, meaning if this is your foot, it suddenly contracts up, stretching the tendon. And oftentimes, if you have predisposed disease, tendonitis, like I mentioned before, it can rupture. As mentioned, it's with higher intensity activity, but it can be seen while hiking too. Trail running, sports, and technical hiking can result in it. The symptoms you see swelling along the Achilles tendon, and often a palpable defect. If you look at this clinical picture here, on the right is a normal appearing tendon. You can see the contour of the Achilles. On the left, it's swollen. You can't make out that contour. Through here, there's a defect. And what a subtle difference is looking at the resting tension of the foot here. When the Achilles is attacked, the natural position of the foot pointed down is there. Here on the left, when it's not intact, the foot sits a little more dorsiflex, meaning there's no tension on the tendon to keep it in that position. With Achilles ruptures, it's maybe counterintuitive. Within a couple days, a lot of folks don't have much pain, and you're able to bear weight because the tendon is totally ruptured. There's nothing left there to cause you pain or stretch. So a lot of folks come in well after the fact and didn't realize they ruptured a tendon, and it's a much more challenging condition to treat once it's chronic like that. So those are some general common hiking related conditions. We'll chat about some generalized non-operative management for these things. So the age old, recommendation of RICE, rest, ice, compression, elevation, it's still the mainstay. It's still the way to go for any condition that you start to develop after hiking. Rest, many conditions are from overuse, and it's frankly the most important thing. I find that's the hardest thing to convince patients, is to rest and slow down, especially around here. But unfortunately, a lot of conditions are your body's way of telling you need to rest. Ice is going to be very beneficial, often more beneficial than heat in the beginning, because during the acute inflammatory phase, ice can help decrease the swelling and inflammation in that area, which will ultimately help with your pain. Compression as well helps with the swelling. Intuitively, it just squeezes the swelling out of there. And elevation also matters too. And elevation above the level of the heart is often what's necessary. You're fighting gravity, and heart is the pump of fluid across your body. So in order to elevate above the level of the heart, gravity is then on your side to then pull the fluid out of the foot or the ankle and bring it back to the heart. Anti-inflammatories are critical for pain relief and swelling aid. NSAID specifically, which NSAID, non-steroidal anti-inflammatory, that's your over-the-counter Advil, Aleve, and there's some prescription strength versions of the same thing. Oral versions can cause stomach upset, stomach ulceration, GI bleeds. And so for those with sensitive stomachs or a history of GI issues, topical versions exist. So the brand name is Voltaren, the generic is diclofenac. Both are now over the counter as of 5-10 years ago. They're over the counter now. So something that I recommend to patients if they have issues with tolerating NSAIDs or Advil or ibuprofen. A good rule of thumb, take it if you're not sure what's going on and you want to make it better, take a 2 to 3 week course of the anti-inflammatories. The reason is you want a steady state of anti-inflammatory in your system to help calm down symptoms. A 2 to 3 week course is a safe amount, especially for the over-the-counter drugs. It's very rarely going to cause you long-term issue. Immobilization is also important too. So it's helpful specifically in the initial stages of your pathology or injury. Particularly if symptoms are getting worse, consider getting yourself into a boot or a brace. Examples are a boot brace or a cast, but that's typically not something that I do, but occasionally can happen depending on the situation. The theory is to stabilize the foot and the ankle, minimize motion, and then allow for healing to occur. Now, by design, it will result in stiffness, but the back half of the recovery is functional rehabilitation. So you're working on removing that stiffness, but immobilization is key to let your body heal before you start stressing it again. The type of immobilization depends on the severity or type of condition. In general, typically for most acute injuries, patients go into a boot, short boot or tall boot, depending on the condition. And then after improvement of symptoms, we'll transition into a brace and then progress typically to functional rehab, physical therapy, and the like. The example on the right is what's called a post-operative shoe. That's for more toe injuries, toe fractures, some stress fractures. The difference here is that your ankle is free and mobile. So for certain things, it's easier to get around with this type of condition, this type of brace. I'll briefly touch on operative treatments for these conditions, and then we'll jump into the preventative care. So I mentioned different types of tendonitis, peroneal tendonitis, often associated with tears or instability. Meaning if the condition is continuing to get worse despite non-operative measures, there's usually an underlying tear or disorder within it. So the solution is, as described here, see that tear, we stitch it back together, and oftentimes if they're dislocating or unstable, we repair that groove. For Achilles tendons, tendonitis or ruptures, there's minimally invasive or open options of surgery. The middle picture is your old school classic large incision, find both ends of the tendon and repair it back together. But nowadays, most of the time I do minimally invasive Achilles repair surgery. And these are different examples on the left and the right of ways to make small incisions to repair Achilles tendon in the setting of tendonitis. Ankle sprain surgery. Ankle sprains involve tearing of ligaments, typically your lateral ankle ligaments. There's many different ways to repair them. This is one example of it using different sutures. But a common way that I use is use what's called anchors, where we drill into the bone a device. It's a non-metallic device that has sutures attached to it that then pulls the ligament back down to bone, making it stronger, making it tighter. Fracture surgery, one of the most common things that I see that I do. And when bones are broken, we line them up again and use a combination of plates and screws to keep them in place. The purpose of the plates and screws are to allow the bone to heal and keep them from moving while they're healing. And then once the fracture is fully healed, the plates and screws are often not necessary and can be removed if need be. But these are all different types of surgeries I've done for different conditions. This is a combination of a talus fracture and an ankle fracture. This is a calcaneus fracture. You can see a plate on the heel bone. This is an ankle fracture, what's called a trimalleolar ankle fracture. And this is an example of that Jones fracture, which is intramedullary screw. This is an example of what's called a Lisfranc injury, 2 screws to stabilize the joint there. Now I'll jump right into the preventative care, because ultimately that's the best way to avoid a lot of these conditions, a lot of these pathologies. So, the first thing that matters is what is supporting your shoes when you're walking, when you're hiking. So good supportive shoes are generally good for overall foot and ankle hygiene, regardless of whether or not you're hiking. In general, a good rule of thumb, the thicker the sole, the more support given. It cushions the foot, provides support for different parts of your foot, especially the older you get, different parts of your foot tend to wear out. The cartilage, the joints, the tendons, the ligaments, they wear out. The more cushion, the better. The less flexibility in the shoe, the sole, the better. Now, it's not a blanket statement, but in general, the stiffer the shoe, the better, because if the shoe does not bend, then the joints of your foot do not bend, which means they're getting less stress. So that's often a good rule of thumb. When in doubt, try the more stiffer shoes. Now, hiking boots, the reason they're so stiff is for this reason. They can accommodate different parts of the ground, different surfaces, but they provide support as well. You can supplement your shoes with different orthotics. For the majority of the population, over-the-counter versions work for most people. I very rarely recommend getting custom orthotics, but it's for people with very unique shaped feet, whether they're really high arch, really flat feet, or have been through multiple previous surgeries that require them to accommodate their foot better. But typically over-the-counter versions work best, and you can get those in many running shoe stores. The goal, similar to the shoe, is to provide additional cushion and support. Many different types exist, and I recommend trying different styles and see what feels best, because everyone's foot's going to be a little bit different. So go to a running shoe store. They often will let you try different orthotics on, see what's best for your foot, and go from there. So preventative care, metatarsal pads. So these are going to be really helpful for those two conditions I mentioned before, Morton's neuroma and metatarsalgia. These pads are adhesive, and you can stick them either on your foot or in your shoe, and sometimes they can be built into the orthotic. The premise of the metatarsal pad is to offload the area of pain. So typically with a Morton's neuroma or metatarsalgia, it's in this region that you feel the symptoms. The pad is designed to be placed below or away from that, because when you take a step, this part of your foot will now strike the ground because of that pad before the ball of the foot does, which then takes pressure off of it. So a common mistake I see, people put the pads where it hurts, and it just exacerbates the symptoms because you're putting more pressure in that area. So it's a relatively simple thing to try and to do, and it often works well specifically for metatarsalgia or Morton's neuroma. Ankle braces are key, and that's the reason or a big reason why hiking boots are taller and support the ankle. Now, stiffer, taller hiking boots work well, but ankle braces with good stiff shoes are probably the best combination here. And the reason is the ankle braces can be more form-fitting. You can really tighten them down to fit your ankle really well. And there's a huge variety. The purpose of these braces are to prevent rotational or twisting injury. Taping is similar to bracing, but it doesn't last as long. As you might imagine, right when you apply the tape, that's when it's going to be your strongest. But slowly over time, as the adhesive wears off, it can weaken. But you can functionally tape similar to an ankle brace, but it's usually easier to get an ankle brace. There's different types and stiffness of ankle brace. I like typically somewhere in the middle. So this is what's called an air cast, where there's two hard pieces on the side with Velcro straps. It's usually uncomfortable, but for more severe injuries can help. One on the bottom right is a sleeve that's going to feel better. It's mainly just applying compression, not doing a whole lot for support. This one in the middle is typically one that I recommend to patients. It's a combination of laces and Velcro straps to allow you to cinch it down, tighten it, and also support your ankle without being too bulky. Physical therapy is a big and important part of both recovery and for preventative treatment when it comes to preventing hiking injuries. Typically for physical therapy after an injury or after development of an overuse type condition, we don't begin it immediately. We wait until a period of immobilization or the period of when the inflammation can calm down, then you begin physical therapy. If you try to do physical therapy too soon, it'll only exacerbate the symptoms because you are, purposefully working that part of your body, and if it's not ready for it yet, it will hurt more. A lot of folks, instead of electing to go to physical therapy multiple times over the course of a few months, they go to physical therapy a handful of times, tell them, hey, I like a home exercise program, and they give you a sheet of exercises to do, but at least going to the therapist to learn how to do them properly is always beneficial. And that's for recovering from injury, but preventative stretching is going to be one of the keys to prevent these injuries from happening. Now, specifically calf stretching. A lot of folks who are active, they're very strong calves. Hiking requires you to have to push off of the ground to go over elevated surfaces. You're going to strengthen your calves, but unless you are spending time to stretch your calves, you're often going to be very tight. Strength and looseness and being stretched out are opposite ends of the spectrum. So you have to go out of your way to maintain flexibility when you have strength. So a lot of conditions can result from calf tightness. So I strongly recommend this runner stretch. If you've been in my clinic before, I probably demonstrated the stretch to you. This is really key. Keeping your knee straight, the back leg knee straight, the back heel on the ground, and bending your knee forward. What that does is specifically stretch the gastroc muscle of your calf, which is often what's tight in a lot of people, which can cause different conditions like plantar fasciitis or metatarsalgia. And I strongly recommend, if you find some good stretches that you like, incorporate it into your daily routine. Whether that's first thing when you wake up in the morning, before you hike, after you hike, spending 5 minutes a few times a day is going to be worth it in the long term. This is an example of a generalized physical therapy regimen or protocol, what people do after an injury. In the acute phase, you're focusing on tissue protection, and you control pain, manual therapy, some ice elevation compression, and you're trying to really get some range of motion back. The intermediate phase, you're progressively increasing your load and work on gaining full range of motion and make sure your strength and balance are where they would need to be. The last phase of therapy, you're going towards sport-based or activity-based function, plyometrics, running, etc. But this is kind of what your therapist, when you meet with them, will talk to you about. And you always want to start your relationship with your therapist by stating your goals and say, hey, this is what I'm trying to get back to, this is what I would like to do, and then they'll tailor their regimen for you. So in summary, try to summarize all that I went through today. Wear appropriate shoes, and ultimately that's what's going to make or break. I mentioned stiff shoes, supportive shoes. It's not going to work for everyone, but if you're not sure where to start, that's a good place to start, because how your foot strikes the ground is ultimately going to influence whether you develop these conditions or whether you develop an injury. Daily stretching routine and or plus or minus physical therapy, that's a really simple thing you can add to your daily routine. And I mentioned calf stretches. That's going to be the biggest bang for your buck. If you're not stretching your calf daily, I highly recommend it. It's going to prevent a lot of conditions that can come your way. Basic bracing to support the ankle or foot, especially if you have a history of ankle sprains. If you haven't already, if you have a history especially, it's probably only a matter of time before you sprain it again. So when you go hiking, especially if it's going to be technical, treacherous, uneven surfaces, consider a brace. It will really make a difference, and certainly folks who don't wear it often regret it. If you get injured and it hurts and you're not sure, it's hard to put weight on it, when in doubt, get an x-ray. You're never wrong to get an x-ray, and at the very least, if it's negative or normal, you got peace of mind knowing it's not a more severe condition. But I see too often injuries that are missed because patients wait too long to get an x-ray, and that can affect their outcome in the long term. And in general, most conditions do improve with rest and time, and the key is the rest. And a lot of folks get a condition, get an injury, overuse, tendonitis, they try to push through it. That's human nature, especially folks that are active, to try to push through it, because for a lot of time in our life, that was usually enough to get by. But things change, our conditions can change, our bodies change, and resting, if you're noticing it's not getting better, really analyze, am I giving my foot, my ankle, my knee the rest it needs? And if not, then that's probably a good place to start. So I want to thank everyone for taking time out of their day to listen to my lecture. And at this point, we'll open it up to questions.
Thank you so much, Dr. Yerrapragada. That was very informational, and we do want to remind our audience that now is the time to put your general questions in the chat box below the video, and we'll get to just as many as we can. We have had some that have already come in, and we'll ask those in no particular order. This person has end-stage arthritis. It's in their ankle. They're having some relief from lidocaine patches. Is it okay to continue that treatment?
Certainly. So the lidocaine patches for bad arthritis in the ankle, it's not doing much to address the underlying condition, but it can provide temporary relief. And it essentially just numbs and deadens the nerves in that area to provide relief. Ultimately, the pain that you get from bad arthritis or end-stage arthritis of the ankle is from inflammation. So if you're someone that can tolerate anti-inflammatories, that will potentially give you more sustained long-term relief. Especially if topical lidocaine patches work well, that's someone you could consider trying the topical Voltaren gel or anti-inflammatory cream. That's not a bad idea. If it ever gets bad enough to where those things are no longer working, if you haven't already, you can consider steroid injections. But that's a different discussion for another day. But those are the types of things you could try to maintain your activity when you have bad ankle arthritis.
You addressed different features in hiking shoes, as well as, high top versus regular, height shoes. Is there a best brand or anything else to add to that discussion that will reduce a sprained or a turned ankle?
So, in general, there's no one brand that I say is the best out there. Many brands have their version of the stiff supportive shoe. Again, if you've been in my clinic, a brand that I often default to, Hoka's, they make really supportive, stiff shoes, good for running and good for hiking. But the hiking boot versions of these shoe brands are often good as well. I would caution when you're looking for shoes, if you're someone that has a history of ankle sprains or instability of the ankle, just wearing high top ankle boots are often not enough to protect you. Reason being, they often don't go high enough and they're often not as tight enough and firm enough to still prevent that twisting type injury. So to offer yourself the best protection, it's a combination of a brace on top of those good supportive tennis shoes. And like I said, most brands have a version of that.
Okay. This person asks, how can they quickly heal plantar fasciitis due to overuse? Or can they quickly heal it?
Yeah, plantar fasciitis can often be a long-term lingering thing. If it's something that you recently had or been dealing with for some time, the first thing you want to consider is how often are you stretching this? If it's something that's come up pretty acutely, last couple weeks or so, then rest would be my first recommendation. Rest, anti-inflammatories, elevation, compression, that type of thing. But if it's been going on for months and months, I would start now and say, hey, I'm going to start stretching. That runner stretch that I mentioned in my presentation, that's going to be key for you, specifically stretching your calf muscle. But doing those dedicated stretching multiple times a day, every day, you're going to start to notice improvement. If you feel like you've done those things, the next step up from that is to do a steroid injection. And steroids are powerful anti-inflammatories. And what those injections do is focally target the plantar fascia, provide anti-inflammatory relief right to that area, and quickly reduce the symptoms. But with those injections, I tell everybody, I need you to stretch. So continue stretching, otherwise it'll come back again.
This person has very flat feet. They have a level 2 sprained ankle. What's the best way to get their foot stronger? They do not want surgery if at all possible.
So if that's someone or that's a type of condition that if you haven't done physical therapy or tried physical therapy, that's where I would turn you to. PT is usually our best defense at preventing the need or needing a surgery. So what physical therapy will often work with you are stabilizing or trying to strengthen the muscles that support the arch of your foot. So if you've got a flat foot, the tendon that typically is the most injured is the posterior tibialis tendon, the tendon that inverts your foot. So therapy will work on strengthening that tendon, trying to get it loose. Things that you can also do if you haven't already, orthotics in your foot, or in your shoes, can help raise your arch. Now, that's not going to be a long-term solution, meaning permanently raise your arch, but it will support your foot better so that you're less likely to roll or sprain your ankle in the future.
Okay. Do you recommend the use of hiking poles, and if so, can you discuss their proper use?
Sure. Hiking poles, I think, are a great idea. My recommendation or use for them or need for them is for balance and support. So if you're someone who has the tendency to fall or has the risk of falling, that's the purpose of the hiking pole, is to prevent you from falling. Now, in terms of proper use, I'll leave it up to the patients in terms of how to use it, but it is a balance restoring or balance maintaining function. They talk about it can relieve some stress off the foot and decrease the pressure. You're still putting your full body weight through the foot and climbing, but to properly use the poles, in my opinion, it's to prevent a fall, prevent a twisting type injury. So if you're concerned, that's always a good recommendation.
This person is 11 weeks post-op. They had a broken fibula and ankle. They now have hardware. She's worried, what about if she twists her ankle hiking now? Would you recommend eventually getting the hardware out? And what happens if she rolls, or if they roll the ankle? Will it sprain?
Yeah, so it ultimately will depend on how, if you were to twist your ankle or roll your ankle in the future, how you do so. Because a roll of the ankle can go anywhere from a mild sprain to all the way to a fracture. So you can still just sprain your ankle like you normally would have prior to your fracture, even when you have hardware in place. If you have an injury that's strong enough to theoretically break your ankle again, the plates where they are, the plates and screws will prevent a fracture from happening in that location. However, you can still get a fracture where the plate isn't. So typically the place directly above the plate is called a stress riser, and that area is going to be a little bit weaker than the rest of the bone, and you could break there. So in terms of your question of whether or not you should get the hardware out, if you have symptoms or pain from the hardware, and in some folks, the hardware can irritate you when wearing tight boots or tight shoes, that's a reason to take it out. But if it's not bothering you, not causing you pain, in my opinion, there's no reason to take it out, and they're designed to stay in forever.
Okay. This next question is a little specific, but we'll go ahead and ask it. This person's daughter had a rostrum procedure. That was 5 months ago. She still has nerve pain. She also recently rolled it. What do you recommend for recovery and to reduce the nerve pain? Do you think it's going to go away?
Nerve pain is tricky to manage, especially post-surgery. In general, nerves can take up to 18 months to fully heal, and there's no great way to assess healing in a nerve besides symptoms. There's no imaging study to really tell how much improvement has happened from a nerve injury. There are medications that exist, and I would consider talking to your surgeon about that if they haven't talked to you already. And these medications, what they're designed to do is deaden and decrease the symptoms related to nerve symptoms. They can have some side effects, namely sedation and drowsiness, but there are some medications that exist. If you've rolled your ankle again, despite having a brostrom, and within 5 months of the surgery, I would strongly recommend seeing your surgeon or seeking another opinion about whether or not the repair has failed or not. And that's a clinical exam, sometimes maybe an MRI. But at least in the short term, before you have a chance to see them, I would go back into a boot. I'm sure as part of your recovery, you were probably in a boot. So in the short term, I would go back into the walking boot to help stabilize it and protect it.
Okay, thank you. So when you have an Achilles tear and surgery for that, how long is the recovery?
So the recovery can be a long one. It's 9 months to a year to recover 100%. A lot of professional athletes, they get Achilles tears, they get the surgery, get it repaired. They're out usually for a season at least. And the reason is the calf muscle, when you're not walking on it and you have to be off of this for a good 6 to 8 weeks, it atrophies. And getting that strength back is a long process, a lot longer than you think. So, typically for my patients, I have them walking or fully weight bearing by 6 weeks. They're out of a boot at 8 weeks. But from 8 weeks to 9 months or 8 weeks to a year, you're just building strength. And it is tedious. It is sometimes discouraging, but patience is what I have to preach to tell folks is it just takes time. But 9 months to a year is typically on average.
Can you speak about PRP for tendon tear?
So PRP stands for platelet-rich plasma. The premise behind that is you draw blood, you spin it down in a centrifuge down to growth factors and re-inject it into certain locations. So when it comes to PRP for tendon tears or tendinitis, that's actually where the best evidence and the best literature is currently. Depending on the part of the body, there's better literature than others. So, people out there are getting PRP injections in parts of the body that don't have the best evidence yet. Now, that doesn't mean it's not going to get there. It might, but right now there isn't the best evidence. In the foot and the ankle, the mid-substance of the Achilles, so chronic Achilles tendonitis, specifically the mid-substance, and for plantar fasciitis, there are some papers out there that suggest that PRP can help. As part of the recovery process after a PRP injection, it involves immobilization. So there is a little bit of a recovery that comes with PRP injection, but in certain parts of the body, it certainly can work, specifically for tendon-type tears or tendon-type issues.
Another shoe question. We'll probably still have a few. This person doesn't care for hiking boots. They kind of rub and hurt. Do you have an opinion about, whether they should push through or just go to a tennis shoe?
What I would probably say to that is if hiking boots are causing that much of a difficulty, I would consider tennis shoes. And you can supplement those tennis shoes with braces, like I mentioned, different types of ankle brace that may be more form-fitting, which would help prevent the rubbing. But the concern of the rubbing is that, one, it could cause focal irritation, a pressure sore, and maybe even a wound. But two, you can walk differently because you're afraid of having it rub on your ankle, which can lead to compensatory tendonitis. You can throw off your gait, meaning affecting your knee, your hip, and your back. So anything that that causes pain, I generally try to say avoid that activity or avoid that. So I would really consider going to a tennis shoe and supplementing that with a brace.
Okay, thank you. Do most insurances cover preventative care for physical therapy treatments that you mentioned?
Yes. So I would say for most conditions, insurance companies are big proponents of physical therapy before going to a surgery or needing something. In terms of preventative care, it often varies state by state, but Colorado is a state where you do not need a physician or a provider referral to go to physical therapy. And most insurance companies have cutouts for that type of care with physical therapy. So it'll depend on the insurance. Here in Colorado, you're safe to go to physical therapy or able to without a provider's referral. But I would say for most insurances, there usually is a carve out to allow for physical therapy. There's set number of sessions you can do per year, per month. It varies, but usually there is.
For vitamin D, what type and dosage should you take, and any other supplements?
So it's vitamin D3. They come in many forms: tablets, pills, powders, and the dose I typically recommend to patients is 4,000 IU a day. Tablets can be 500, 1,000, or 2,000 IU pills or capsules. 4,000 per day is usually a safe dose. For context, treatment level dosing for vitamin D deficiency is 35,000 IU. So 4,000 a day is a pretty safe dose. Now, if you're going to be taking that, what I would suggest is if you have a primary care doctor, let them know so that they can make sure it doesn't interact or interfere with any other medication you're taking. But typically 4,000 is a safe dose. Other supplements, bone health wise, calcium is often something people talk about. Generally, through our diets, people get a good amount of calcium. And a potential risk of taking too much calcium is it can actually cause calcification elsewhere in your body. So I typically don't tell folks to go out of their way to get calcium unless there's a reason to, if there's lab studies or deficiencies elsewhere. But vitamin D3 is a very safe drug and well tolerated.
Okay. Do you do bunion surgery?
I do. And bunion surgery there's a lot of different ways to do bunion surgery, a lot of different types, and all that depends on the severity of the bunion. Nowadays, what I'm doing for a lot of my bunion surgeries, there's minimally invasive approaches for this, meaning 3 1-centimeter incisions, and through those incisions, we make the necessary bone cuts to straighten the toe out. And the biggest benefit of that is it allows immediate weight bearing. So while, without knowing the context of everyone's bunion, I can't promise you that you'll get that type of surgery because it will depend on your type of bunion, how severe it is. But a lot of folks are candidates for that, and I try to be as minimally invasive as I can for all my surgeries.
Barefoot shoes are popular now. This person likes to wear them, and it seems to make sense to increase strength and mobility. Do you have thoughts on those barefoot shoes?
Yeah, so when, in general, if you're healthy and you don't have foot pathology, yes, the premise behind the barefoot shoes is to try to strengthen the muscles. Where people can go wrong with that is if they start to develop conditions, tendinitis, arthritis, or other degenerative or chronic conditions, those barefoot shoes are no longer helping because while you're trying to strengthen those muscles of your foot, you're also putting a lot of stress on those joints and tendons as well while doing so. So there's usually a crossover point where people who can tolerate the barefoot shoes may not be able to tolerate them anymore. And that's different for everybody. So, I mentioned the stiffer supportive shoes. It's not a rule of thumb for everybody, but for most folks, they feel better with it. So I tell folks, if the barefoot shoes work for you and they support you, more power to you. But if you're looking for a shoe and you're neutral and you haven't tried one, most people probably tolerate the stiffer shoes and supportive shoes better than the barefoot shoes.
Okay. Back to supplements. This person wants to know what might help strengthen tendons. For instance, glucosamine, collagen, omega XL.
Yeah, so collagen, glucosamine, they've been well studied, and as of now, there's no great evidence to say that it can strengthen tendons, ligaments, or cartilage, because all those structures have different types of collagen in them as part of their structure. Now, when it comes to those supplements, I tell folks, it's safe to take them. If they're FDA approved, these supplements are able to be on the shelves because they're safe and tolerable, but they don't have to prove efficacy, meaning you don't have to prove or show that they do anything. They just have to prove that they're not unsafe. So I tell folks, if it works for you and if you believe in it, certainly take it. But I can't in good faith say, go buy this supplement and take this. There's not a lot of great evidence specifically for tendon, cartilage, or ligaments. Same thing with glucosamine. It's designed, or the premise is to help joint strength. But unfortunately, with the trials that have been rigorously studied, there's not a lot of great evidence for it as well. But again, a lot of good anecdotal evidence. Some people swear by it. I can't in good faith recommend it. There's not a lot of great evidence for it.
Do the recommendations you provided generally fit for a plantar plate rupture?
So plantar plate ruptures, what's interesting about that, the topic metatarsalgia that I mentioned, they're often associated with plantar plate ruptures, meaning the degenerative condition that can lead to metatarsalgia is often a rupture of the plantar plate. And what the plantar plate is a sling of tissue that's on the bottom of your foot that connects the metatarsal to the base of the toe. So oftentimes people that have metatarsalgia and have tried everything and it's to the point of considering a surgery, if you were to get an MRI, they'll show plantar plate tears. So if you had an acute plantar plate rupture, meaning there was an injury, a tear, then conceivably you could repair it primarily or do a surgery to fix it. However, most of the time, people get these plantar plate tears for chronic degenerative conditions, and it is not a good idea to try to repair poor tissue to poor tissue, because the poor tissue is what caused the tearing. So in general, a plantar plate repair for degenerative condition is often not successful.
Okay. Back to bunions. Is there a solution to continue hiking, running without aggravating or making them worse?
So bunions, unfortunately, it's just finding the right shoe for you. So on average, wider shoes are going to be better that support the width of your foot, because that bunion, it rubs against shoes. Another common reason bunions bother folks is that the big toe crosses over or crosses under the second toe or rubs against it. If that's your problem, then you can get small toe spacers to stick in your shoe between the first and second toe. There's a lot of products out there that advertise or try to say, we can correct the bunion, we can straighten it out with different types of spacers or splints or things. Unfortunately, they don't work that well. Meaning, while you're using them, the toe will not worsen, but as soon as you stop using it, the toe is going to go right back. It's not going to reverse the condition, unfortunately. So when it comes to hiking, it's just finding wider shoes, broader shoes. And if you can't, or you struggle, or you get to the point where you don't want to hike because of the bunion, that's a reason to consider a surgery to correct it.
Where can you go to look at these or to purchase these ankle braces? Do you have a brand?
So there's a lot out there. Some running shoe stores will have them, but typically, if you want to go in person, some pharmacies will have it too. It's usually going to be at a doctor's office, orthopedic surgery clinic, along those lines. A lot of folks that come into my clinic looking for ankle braces, and for different socioeconomic reasons, can't get the brace that we have to offer. There's a lot on Amazon that can also provide you, but I would caution you on getting a brace off of Amazon without having a discussion with someone who knows what type of brace you need. So at the very least, if you're unsure or unclear, then it may not be a bad idea to check in with a provider or an orthopedic surgery clinic to have that discussion. And then you can have an educated, thought process of where to get what type of brace that you need.
Okay. So calf stretches were recommended. This person on one side has plantar fasciitis and pain.
Mm-hmm.
Should they still do the calf stretches on both sides?
Yes. So our bodies are mostly symmetric, meaning we all favor one side more than the other. We're right or left-handed, right or left-footed, so we get different conditions on different sides. But it's like for overuse, plantar fasciitis type conditions, it's usually tightness that causes it. If you're tight on one side, you're probably tight on the other side. Not exactly the same, but close. So I would suggest definitely stretch on both sides and try to make both as loose as possible, because you never know, by doing stretches on the side that doesn't hurt, you might be preventing this from happening in the future.
Okay. This person has peroneal tendonitis. They've had it for over a year. They've done multiple things. They've worn a boot, taken anti-inflammatory drugs, etc. PT did not work as well as orthotics. Any suggestions?
So if you tried all those things, they haven't gotten better, and I would consider, if you haven't already, getting an MRI. Only because at that point, if nothing's getting better, you may have some significant tearing of those tendons. And there's always a point at which, if your tearing or your disease is bad enough, then the non-operative stuff doesn't work, and that's why we have those surgeries. That's why surgery exists, to fix it. But if you haven't, I would consider getting an MRI to evaluate those tendons. And depending on what that shows, it's either surgery or those more exotic treatments like I mentioned, PRP and other things. It depends on, again, how bad it is and what your appetite is to do those things.
Okay. This person had a good result, and then now they're back to a bad result. So they had a longitudinal tear in their tibialis posterior. That was about a year old. They did about 3 months PT. That worked really well. It really strengthened it. No more inflammation. But then they re-injured it. So now what?
If PT worked for you, I would try that first. I would not jump to a surgery right away. I would try the physical therapy again, because to your point, if it worked well for you last time, there's a chance your body can heal this again. And if it doesn't work, if it doesn't get better, or it feels like it's worsening, then I would consider something like an MRI or advanced imaging. But I would go back to PT. If it worked well before, there's a chance it could work well again.
Okay. If you have osteoporosis, can you run? And how do you prevent fracture without op meds?
So osteoporosis is an issue of poor bone density. What actually improves our body's bone density is weight bearing. It's compressive activities on the bone actually strengthens it. So you want to be doing things like running, maybe not to the extreme of running, depending on the type of person you are, but running is safe to do. It actually will strengthen your bone quality. The prevention of fracture is falls. So depending on the activity that you do, you want to make sure you're safe and trying to minimize falling, because hip fractures, shoulder fractures, wrist fractures, compression fractures of the spine, these are all osteoporotic fractures. And if typically they happen with falls or low energy mechanisms. So I encourage you to stay active. And if that's running for you, encourage you to run, but it's falling that you need to avoid.
Okay. Back to calf stretching. Do you recommend supplementing the calf stretching using a muscle roller stick?
So I think that's reasonable to do. Some people have intrinsic knots or adhesions in their fascia underlying their muscle that may prevent them from stretching as well as they can. If that's something that you like or want to consider, I would recommend either foam rolling or massage or some combination prior to stretch and then stretch, because by doing so you'll loosen it up and then do your stretching. Not everyone needs it, but some people, again, it benefits them and it feels better. That's the order that I would do it in.
Okay, thank you for that. This person was recently diagnosed with calcific tendonitis. Can you comment on outcomes using iontophoresis or phonophoresis?
So calcific tendonitis, without knowing exactly what tendon is involved, it just means calcification of the tendon themselves, and that can happen with severe inflammation. Our body's response to healing can be exacerbated and result in bone formation and calcium formation in the tendon. Iontophoresis and the other indication or the treatment you mentioned, those are different ways to try to break up the calcium and break up the bone. It can help. It's hard to say how much it will, however, but when you have a condition that is painful and you're trying things to where the path at the end is a surgery, I would say it's a relatively low risk thing to try. The iontophoresis and the other indication that you mentioned, those are relatively low risk things to do. So if you have the means and the capacity and the patience to do those things, I recommend it. But ultimately, for a chronic condition like that, if it doesn't get better, you're looking at a surgery.
We're going to squeeze in a couple more questions here, then wrap it up. Sure. What can you do for Rockerfoot syndrome, Charcot deformity?
So Charcot deformity, that's a complicated condition. So in being brief, it's a condition where the nerves of your foot and your ankle have been injured in some way where you don't have normal sensation, and as a result, the bones and the joints start to deform. They can disintegrate, they can fall, and your arch can collapse, and you get that kind of rocker bottom or rocker sole deformity as a result. It's a complicated question because it fundamentally depends on how bad your Charcot deformity is and what stage you're in. It's commonly in the setting of diabetes, but it can also be in the setting of other peripheral neuropathy and nerve type conditions. What I would say is, if you are worried or concerned, I would go see a specialist, because the fear and the worst outcome with the Charcot deformity is a wound that develops into an infection, meaning if the bone collapses, it puts pressure on the skin, you can develop a wound, and because you have poor sensation in the foot, you don't notice that you have a wound, it can get infected, and then worst case scenario, if it doesn't get treated, is an amputation. So I would say, if you haven't seen someone or you're worried about it, I would go see a specialist, because it's a nuanced discussion and it's patient specific.
Okay, thank you. So this person sometimes has their ankles give way when they're just plain Jane walking. And when that happens, it's all obviously unstable and also a little bit painful. Do you know why or what they should do?
Usually that's the story I hear in someone who's had multiple ankle sprains in their past, whether in their youth or recently. And it goes back to trying those things that I mentioned. If you haven't tried physical therapy, consider physical therapy to strengthen the stabilizing muscles of your ankle. If this is happening regularly enough, consider bracing, or taping or something, just even with your day-to-day life. If those things don't help or untenable in your lifestyle, then I would consider getting an MRI if you haven't already, to look at the integrity of the ligaments. But with most things, try strengthening, try dedicated PT for the ankle. That's a good place to start.
Thank you for all the specifics that you've given for the answers tonight, but we have come to the end of our time. A recording of tonight's lecture is available at bch.org/livestream. You will receive a post-lecture survey by email. Please take a minute to fill this out. Thank you for joining us, and have a good night.
Thank you, everyone.